Hi, it's a great pleasure to be speaking with you in the next half hour about something that is pertinent to everyone that's listening, either to you or a loved one, a friend, and we're going to be speaking now about heart disease, stroke, diabetes. You know, these are words that affect each one of us throughout our lives and are affecting some of you even right now. I'm Dr. Richard Michal. I have a concierge practice. It's the MDVIP practice, and you can see the listing there. It's my privilege this evening to have Dr. William Cromwell with us. I've known Bill for years. We won't give away exactly how long. That's top secret.
Right.
But it's been a long time. And he's a wonderful colleague. He is a cholesterol specialist. And he is, I will say this because he probably won't, but he is world renowned. I joke about that I will go over an hour to see him and hear him lecture. Every time it might be on a similar topic, but I learn something every time I'm under his teaching and his tutorial. And throughout the years, we've worked together on many difficult patients who have difficult, hard to discern issues going on in their lives, and he's been a wonderful colleague, and we've really worked together in that arena. So, you know, it's with great pleasure that I can bring him in to kind of offer his teaching, his views on these very pertinent subjects of heart disease, prediabetes, diabetes, and cholesterol management. He's published numerous large papers, and he's kind of unique. I tell my patients that he is unique in that he's a researcher, but he also is a clinician. He kind of has one foot in both arenas, and he's doing some very, very exciting things that we may get to on this presentation or on a future presentation. So with all that being said, let me go ahead and just shift to Dr. Cromwell. You know, we have the largest, COVID right now has been a big disease process going on. It's affecting everyone's lives. And yet, if you look at the numbers, it's not the number one killer in our country. And, you know, cardiovascular disease has been and continues to be. And, you know, one of the things that as clinicians, you know, we want to try to move that curve if you can, and move when that affects people's lives. You know, I say, if I'm in my 80s and 90s, we're ready to go to heaven. But maybe not so much right now. And so, you know, we'll start off by just, if you can give people a little bit about your background, your training, and what your practice has been in Raleigh. And I've stolen him away a little bit to help me with my patients in my practice. But if you can give everybody just kind of a little background about yourself.
Well, sure. Well, first, thank you for that overly generous introduction. It's very kind. I've been really very fortunate. I look back, I was thinking about this the other day. I started my first lipid clinic in 1988. So if you think back to 30 plus years of medical practice, what did we know in 1988? And what would have kind of motivated me to follow this path and continue on what they're doing? It really was pretty simple. I went to medical school and asked a question: what kills people? Vascular disease. Well, how do you stop it? Nobody was really sure. And there were some ideas. There were major risk factors: high blood pressure, diabetes, family history, some things you could change, some things you couldn't. But one of the things that was on the list had to do with cholesterol. So I was a chemist who went to medical school. You measure things, sound like a pretty good fit. So I asked the question, well, can I just do cholesterol as a specialty? And people looked at me like, nobody does that. Why would you ever want to do that? But it seemed to me that there was a real future there because we did not have the agents we have today. We didn't understand the disease the way we understand it today. And there are really a lot of things we can do. A lot of things that you do for your patients, I do with my patients, if we just take advantage of the tools available to us. if we have the time to unpack what's going on in an individual's lives, all the moving parts that influence heart disease, then we really can do a good job one patient at a time. That's what it really boils down to. So with that as my kind of intro into, I think I want to do cholesterol, I took a path that would basically train me in that way. One of my mentors was a guy at LSU School of Medicine where I went to medical school, and he said, well, you'll have to see kids because they have inherited disorders, and you'll have to see older folks because they have a lot of the events. So I said, well, what specialty helps me take care of kids to older folks? Family medicine. So I did a family medicine residency, and I said, well, that was good, but I really want to do lipids. How do I do that? And so I did my lipid fellowship at WashU in St. Louis, after which, when I got finished, I asked my mentor there, what should I do next? He said, go home. Go home, because now you've been trained to practice. And so I went home, which was in Kentucky, and started one of the first private practice lipid clinics in the country with what we knew at the time. And what did we know at the time? We knew that very high cholesterol levels were associated with risk of heart disease. But we also knew something else that somehow got lost in the shuffle, and that is that there are carriers of cholesterol that are really what do the harm or the benefit in the wall of a person's artery. Now, we know these things by letter names, and our viewers know LDL is bad and HDL is good, and that's true. But we think of these in terms of LDL cholesterol, the bad cholesterol, or HDL cholesterol, the good cholesterol. One of the things that makes a difference but isn't well known is that those letters actually refer to the carrier that moves the cholesterol around. So if we actually spell out what LDL is, it's low density lipoprotein, which is like a tennis ball, hollow in the middle. You put cholesterol inside of it, and it carries it around the body to various places. Well, the problem is that if you have a lot of LDL, then you will have that deposit in the wall of arteries, causing increased risk for heart attacks and strokes. And so that little bit of an extra wrinkle, that the LDL is a particle and not just the cholesterol, is what I spent about 25 years of my life seeking to understand, doing some research, and it was fascinating. So I've been very fortunate to work with great people through the years, just great people. Gus Schoenfeld was my mentor when I was doing my lipid work. My research partner for 25 plus years has been Jim Otvos, who is a guy who revolutionized what we measure and what it means to treat people who have risk that's related to the lipoproteins that carry cholesterol around. And it is my pleasure to continue to keep a foot in a lot of camps. I do keep a foot in the research camp, and as such I can ask questions of people who are really on the cutting edge and helping us all understand new things. I like to take care of people. I think it doesn't make a lot of difference if it's not impacting people's lives. And I think people many times don't have the opportunity to sit down and really have a conversation with their providers. I tell people all the time, my best tool is my time. You take my time away, you've taken my best tool away. So if I could spend time with my patients, helping them understand there's cholesterol and what carries it around, and if you have a lot of what carries it around, you either made too much of it, you didn't get rid of it, or both. And it can really be that simple. And so we have this conversation about things that carry cholesterol and how much do you have? Did you make too much? Did you not get rid of it? And what can we do? And what we know now, and what you have really focused a lot on in your practice is there are some very common problems that sometimes aren't thought through in terms of how does this impact my cholesterol? How does this impact my blood sugar? How does this impact my blood pressure? How does this impact my risk for heart disease or stroke or diabetes? And there is a single pathway that has a lot to do with all of those things. And that's what we spend a lot of our time trying to help people understand is if you could do kind of like City Slickers, the movie, if you could do one thing, the curly, one thing, if you could do the one thing that would make a big difference, it would be to find the cause that drives those individual elements and fix it. Just fix the root cause. And that root cause has a lot to do with prediabetes, something we call insulin resistance, and people have heard about insulin resistance. There's a lot that has been written about diets and exercise and what works, what doesn't work. So it's a lot of information that's somewhat controversial, but if you understand where somebody is with these issues, you can construct a very personalized plan. They can be successful with diet, they can be successful with activity, they can lose some weight, they can be healthier. And the good news is, the better they do those things, the less medicine they need, and the more effective the medicine is that they take. I haven't met too many people who say, can you give me another pill? I got a list, but I'll take another one if you got it, So getting people off of medicines is really not just a myth. You can do that, but it does take, I think, a different approach. It takes an approach that, kind of takes all this science that we've kind of come to understand over the past 20, 30 years, take it to the bedside, and help people understand, there are 4 or 5 really important pieces of information. And if you could just give me those 4 or 5 pieces of information, I can do a lot for you.
Dr. Cromwell, you mentioned that there are standard things and names of things that people have come to know on their lab tests.
Right.
The HDL, the LDL, the total cholesterol. But I think I heard you also say, but that's not the whole picture, that there are other things that are not indicated or even measured on a standard cholesterol test. Can you kind of explore that just a little bit with our audience and tell us, how that might make a difference and how sometimes even a standard cholesterol test could possibly be a little misleading at first glance?
Well, it's a great question. I think a lot of our viewers, I know it's true in my house. I've got 5 kids who are 18 to 32. They grew up with me as dad, and they know all the crazy stuff that we've done. And yet, my youngest, who's a freshman in college, just had a lecture on good cholesterol and bad cholesterol, which I thought was very interesting. So he called me and said, this is what they said. And I said, well, that's generally true, but there's a rest of the story. So this is the Paul Harvey rest of the story, right? If you think of cholesterol as something our body has to have to be alive, every cell in our body needs cholesterol. We are tuned to need cholesterol. We make most of the cholesterol our body uses. We do consume some in our diet. We have to move it around. Our cells make it on demand. So cholesterol is critical to normal health. And its sister, triglyceride, is another fat that our bodies use, in this case to store energy for a rainy day, but we have to have these fats or we would not live. So to start with, cholesterol is good, and there's nothing wrong with cholesterol, and we have to have it. What happens, though, is that we look at a cholesterol test and we say, if this number is high, then I know how much risk I have. And the challenge is, it's not the cholesterol, it's the particle that carries it. All right, so I'm going to reach for my little bottle of water. So this is my bottle of water, and my bottle of water, when it was given to me, had 1 liter in it, or a half a liter bottle of water. Okay, so if I say a half a liter, I have 1 bottle. If I say I have 1 liter, I have 2 bottles. That's only true if the bottle is full. Now, what happens if the bottle is half empty? Now the math doesn't work anymore. This is the reason why cholesterol gets it right sometimes and it gets it wrong sometimes. I can measure cholesterol in LDL, the bad cholesterol, and a number, say 100 for me and 100 for you, could mean that I have a very different number of those particles. So it sounds a little weird, but remember, the letter name goes with the particle, and it's the number of particles that either hurt you or don't hurt you. And all you're trying to do with cholesterol is figure that out. You're just trying to figure out, do I have a lot of that stuff or not? What happens if the number for cholesterol looks okay, but you have mostly empty bottles and many, many, many of them, many more than you ever thought? You miss the opportunity to say, you've got a problem. You miss the opportunity to say what really gets in the wall of the artery to hurt you, you got too much of. And we need to help you bring that down. So this is where some of those extra tests can come in. You can measure directly how many of those particles you have. You don't have to guess. I use the analogy sometimes, if you were a lifeguard at a beach and you came on, it's your shift, and somebody said you have to write down the number of people in your sector of the beach. So you show up for work, you get in your lifeguard stand, and you start counting t-shirts. I've got 50 t-shirts. And you write that number down. I got 50 t-shirts. And then somebody came behind you and they said, but I counted 100 noses. Oh, now we have a problem. I've got bodies, they all have a nose, and there are 100 of them. But the 50 t-shirts, what happened to the other 50 people? Well, they're on the beach and they didn't have the t-shirt on, right? So this is the difference between something you can have confidence in, a nose count, and something that you hope is right but's wrong a lot of the time, a t-shirt count. And if all people know is a t-shirt count, tell me my cholesterol, I hope you're not on the beach, because you'll get it wrong. And that's what happens. Half of people who we think are healthy have a lot of difference between the cholesterol and the particle number. And it gets worse if you're pre-diabetic. It gets worse if you're diabetic. That number gets up to 3 out of 4 people. So here we are betting the farm on this cholesterol number, which is likely going to let us down as much as 3 out of 4 times. And if you don't have a get-out-of-jail-free card, you're going to look at somebody and say, I think you're fine. And you could be right or you could be wrong. And one of the things we know now is if you lower those numbers of particles, you significantly reduce heart attacks and strokes. So you basically miss an opportunity to help somebody get to a place where they are more likely to benefit than just with their cholesterol number.
Thank you, thank you. Dr. Cromwell, just to follow up on some of our discussion to this point, you know, how, I know that you do a test because we're talking about things that may not have symptomatology. The patient may not be aware that they're building plaque in their arteries. So if you could describe, I know that you do a test that utilizes an ultrasound, but you know, there are companies that go around and they offer that kind of modality, but how is your test different from what people can just get at a screening health fair or something like that?
So what you're describing is what we call non-invasive imaging. So we don't want to poke a hole in somebody. We don't do a heart catheterization to see is there something in there that we need to worry about. We don't want to have to do that. So we either have to use an X-ray or an ultrasound to look at the vessel. And there are reasons why each one works. By ultrasound, what you can do is you can look at a vessel and find the earliest evidence of plaque. By X-ray, you find plaque that's very old, it's calcified. So bones are made of calcium, X-rays see calcium very well, but X-ray doesn't see fat tissue very well. So if you're trying to look at, say, somebody's heart arteries, the coronary arteries, and say, is there an early blockage there? There's a coronary artery calcium test, and it finds those that have calcium in it. That's a very good test when it's positive, but a 0 doesn't mean you're good. And that's something that is important for people to understand. Now, it becomes more likely to be predictive if you're older. So for men who are over 55, women over 65, those are really good times for that test to declare itself. But what do you do for people who may be younger, right? And so let's say we have a 40-year-old man who has a terrible family history, multiple risk factors, high blood pressure, high cholesterol, and he's trying to do his best. He's doing some efforts at diet and exercise, but it's not really moving the needle. You say, I think you need to be on some medicine for this because you have a really high risk and you have bad family history. And he's thinking about it and said, well, I'm not really sure I want to be on medicine because I've heard things about these medicines, these statin drugs. They don't feel good when you take them, a lot of adverse effects. So what can I do to either convince myself I need a medicine or I'm just going to kind of stay put and do my best for a little longer? And this is where some sort of extra information, if I look at your artery and I see a blockage, would that change your mind? Well, sure it would. And this blockage process takes decades to happen. And once you find blockage, the good news is you can do something about it. You can actually treat people so blockages don't get bigger. You can treat people so blockages don't break and cause heart attacks and strokes. You can prevent new blockages from starting. But you don't do any of that unless you know there's a problem in the first place. So by ultrasounding the arteries, I don't get too in the weeds, but you're using a sound wave test, and it's letting you see the artery wall. There are places in the neck artery, the carotid artery, when it comes up by the ear, it divides into an internal and an external. So think of a big Y, a big one coming up and 2 coming off to the side. Where all 3 come together is called the bulb. And the bulb is a place where you see a lot of early disease, as well as the first thing that comes off the internal carotid. Now, if you know that, then you can take your time and you can look at that area very carefully in multiple different ways. And if you see areas that are thick, you can measure them. So a focal area of thickening that's more than 1.5 millimeters is a plaque. You have to look for it. It's like hunting Easter eggs, right? Now, you can hunt Easter eggs from your porch, and you say, "I'll see any Easter eggs." Or you can go out in the yard and kick over some leaves and say, "Well, there's my Easter egg." That's the difference between doing a screening study and doing the interrogation that we do. So if you are going to screen somebody and look in a certain way at certain places, you may see an Easter egg in the yard, but are you motivated to do what's necessary to fully visualize all of those areas to rule out evidence of plaque, right? So it does take a little time. It takes me 20, 25 minutes just to acquire the images. It takes another 20, 25 minutes to read those with the patient and generate the report. So that takes a little while. That's not what screening is designed to do. Screening is designed to get an answer more quickly, to generally put people in a category, bad, good, but not to say, in your case, we have comprehensively evaluated you, and at this point, I find plaque or I don't find plaque. So our goal is to find disease as early as possible, because we can do something about it. And if you find disease in someone's 30s, the benefit they get is a function of how long they improve. Mm-hmm. So think of time as the multiplier, both for risk and benefit. If you have a risk factor and it's only been there for 5 years, that's very different than somebody with the same risk factor who's had it for 40 years. If I lower your risk today and you only have 10 years to see a benefit, there's benefit there. But it would be better if I lowered your risk and you kept that benefit for multiple decades. That's when you get the most benefit. So the earlier you find disease and the earlier you intervene, the better people do.
So, Dr. Cromwell, you've mentioned that there's this thickening that if it gets to a certain size, it's called plaque. And we've heard about plaque buildup. Mm-hmm. Again, for our audience, is it possible to arrest that growth? It seems almost inevitable that it's a current that's pulling us in a bad direction. Mm-hmm. And is it possible to slow that progression or even halt it, or can you even cause it to regress?
So the short answer is yes. And the longer answer is plaque is growing not only because risk factors are there, but there are factors that are being added to the plaque as it grows. LDL. So we're back to that letter name again, LDL. LDL is one of the things that is added to a plaque to make it grow. It's like air that allows a fire to burn. If you want a fire to go out, you take away the air. Take away the air, the fire will burn out. Likewise, if plaque needs certain things to grow, if I take those things away, it's going to have a very hard time growing. And a lot of very good research has shown that depending on how low you get the LDL, you can stop a plaque. You can even get a plaque to shrink somewhat in size. The amount of shrinkage, it depends on who you read, but 10% is considered a pretty good decrease in size in response to lowering LDL. But more importantly, and we haven't quite teased this out yet, 3 out of 4 heart attacks are caused by plaques that break. And when a plaque breaks, a clot forms right on top of the crack. The clot is what stops the blood flow. So your body clots pretty quickly. Cut your thumb, you're going to cut. And it's going to clot pretty quickly. If I have a plaque that breaks and I stop that by a huge clot in my blood vessel can't move blood through there anymore. That's where the heart attack and the stroke occur. Now, the type of plaque that's breaking 3 out of 4 times is not limiting blood flow on its own. It has no symptoms. It's silent. And a silent plaque breaking unexpectedly is catastrophic. And that is what causes a lot of the heart attacks, right? So having these plaques break is called vulnerability, a vulnerable plaque. Vulnerable plaques can be made stable by the same process we're talking about, lowering LDL. So if we stabilize a plaque, it's less likely to break. If we stabilize a plaque, it's less likely to go on to incite a heart attack or a stroke. If we stabilize a plaque, it can actually begin to implode and shrink a little bit in size. and the top gets stronger so it's less likely to break. All of these things happen in response to finding there's a problem and pulling the levers that can influence that significantly, like LDL. Now, that's not the only thing. Smoking cessation, blood pressure control, proper diet and exercise, especially in the case of prediabetes. These are all critical interlocking factors. But as we were talking about LDL, it specifically has been studied and shown a lot of promise in that area.
I know I'm as thrilled to hear Dr. Cromwell speak about this whole idea of how do we reduce our risk of heart attack and stroke. You know, those are huge items that each one of us needs to pay attention to. And Dr. Cromwell's gone through and elucidated, ways that we can detect this. These are silent things going on within us right now. And, we just, in the last segment, we learned that it's possible, once detected, to do something to fight against this.
Mm-hmm.
Now, I was intrigued by your comment, and you started into this. Everybody runs right away to medications, and we'll go there in a moment. But is it possible to juggle this thing in a way that we can impact it with lifestyle changes? And if so, is it something that we can reasonably get at and affect?
So that is a great question. It's a controversial question. There's a lot of opinion out there. I bet a lot of your viewers have seen many different diet books and many different people talk about diets. One's better than another. That's just the world we live in. And so I think part of that is because it is complicated. I think part of that is because people have a shtick and they're kind of pushing their shtick, and that's okay. So what is it that we understand, we think we understand about diet and its relationship to this problem? Well, there are two things. For the majority of people that are watching us tonight, the biggest issue we have is something called insulin resistance. It affects the majority of U.S. Americans. It's not that we don't make insulin, we make plenty of insulin. It's the cells that are supposed to act in response are resistant. That's the liver, the muscle, and fat cells. So if they're not doing what they're supposed to when insulin signals them, then the pancreas has to repeat itself and put more and more insulin out until the job gets done. Now, this insulin resistant state leads us down a certain rabbit hole. And that is that we get more weight around the center of our body. It's very difficult to get rid of. Our triglyceride level goes up. Our blood pressure goes up. Our blood sugar goes up. We become pre-diabetic at some point. So that process goes on for several decades before people usually get detected as having borderline diabetes or diabetes. Now, why is that important? It's important because there are diets that specifically address insulin resistance. And that's one way that people can significantly improve the risk of heart disease, diabetes, and stroke. So if you're that insulin resistant person, people are going to want to talk to you about the types of food you eat and when you eat. Right? So carbohydrates you're familiar with. There are a lot of things that fall into the carbohydrate camp. Cakes, cookies, pies, ice cream, those are carbohydrates, but they're not the healthy ones. There are other carbohydrates that people have heard of that they may not eat as much, like vegetables and fruit. Those are other carbohydrates, right? But the amount and type of carbohydrate you eat directly fuels insulin resistance. So one of the things that people are disappointed to hear is you might need to think about your carbohydrates and tune that so you're not eating the ones that are going to hurt you and taking the amount of carbohydrate down to a more reasonable level in your diet, because we have a lot of carb addicts in this country. All right, so that's one issue. And there goes the hand. And then the next question, we've talked about this last few days, is something that a lot of people have heard about called intermittent fasting. And this is an idea that you don't eat 3 meals a day on a scheduled breakfast, lunch, dinner. No, you have a window of time that you eat, several hours, and once you have finished your window, you don't eat again until the next window the next day. So let's say 8 hours. In that scenario, you would have 8 hours where you could eat a healthy diet, and at the end of your 8 hours, you would wait until the next day and start at the same time. Now, what happens to your body when you're not being fed? It seeks energy from other sources. It has to go hunt for it. And where do you have this energy? In your fat cells. So you are going to turn into a fat burner, and as you burn your fat, you will become more insulin sensitive. Now, how much of a window do you need? A lot of people have different opinions about this. 8 hours, if you've never done a window before, 12 hours could be good. I mean, some people have just not gone 12 hours without eating before, and that's a great place to start. A lot of the research would say something around 6 to 8 hours, you're in the game. And there are people who would suggest you could get by with even less, but that's hard to do. So carbohydrate restriction, intermittent fasting, these are things that have effects that people like. If you stick with it, weight goes down. If you stick with it, you're burning fat, and a lot of your fat stores where you don't want them to be around the center of the body decrease. And as you become more insulin sensitive, blood pressure improves, blood sugar improves, the particles that carry cholesterol can improve. And all of this, then, you're getting healthier, and you need less medicine. Now, that doesn't mean medicine, as you were saying, isn't necessary, but I think of medicine like a mop or a broom. It cleans up a mess, right? So, with 5 kids and a lot of years of little hands and little feet and big messes, there's a mess. You either teach your child not to make a mess, or you're their janitor. So medicines are mops and brooms, and they clean up stuff. Well, what if you didn't have a mess in the first place? What if your diet and exercise decreased your need for medications to a point where they're more effective and you need fewer of them?
Well, speaking about medications, I know a lot of the listeners are probably wondering about the medications that are used to help manage these particles. And I wondered if you could speak a little bit about, because there's a lot of background noise when it comes to statins, and there can be there's a lot of information, but there can be misinformation out there as well. And how do you balance talking to patients about the utility of statins, and are there other non-statin drugs that are available?
Great questions. Would probably take us a lot longer than we have to answer completely. But I will say this. When you think about medicines and whether they are net good or net bad, you have to look at research. And it's really the quality of the data that inform us as to where we like to use the medications that are available to us. Not so many years ago, the guidelines that we use to initiate therapy put a great emphasis on using medicines that had the best effect in decreasing heart attack and stroke. And that happened to be statins. Of all the cholesterol medicines we have available, statins, hands down, have the best quality of data to decrease heart attack, stroke, and related conditions. That's why we use them as our first-line agent in most people. It is also true that many people have had trouble tolerating a statin. And part of that story really goes back to how much statin are you starting with. Now, it was the case back in 1988 when I started my first lipid clinic that the first statin, Mevacor, had just been launched, right? So Mevacor was used and people didn't have a lot of complaints like they do today. And the next statin came along, and the next statin came along, and after we had 2 or 3 statins, we had Mevacor and Zocor and Pravachol, people were tolerating the doses usually used with very few adverse effects. There was a study that came out called the Miracle Study, which showed that for certain people who were in the hospital in what we call an acute coronary syndrome, trying to have a heart attack, that the highest available dose of Lipitor helped them a lot. Well, it turned out that that was not necessarily the only takeaway from that study. And people started using a very liberal amount of very high dose statins as their first dosage. And as people were exposed right off the bat to higher dose, high intensity statin, there were more adverse effects that were complained of. So I think, one of my biases is I like every piece of data to be given consideration. I don't like to cherry pick and say this is good data and this is bad data. All data is good data. So how can things be true? Statins are safe, statins decrease heart attacks, people don't do well when they get statins. How can all of those things be true? A lot of it in my experience has been we should be careful about not giving statins to everyone. We should follow the guidelines as to who is a statin eligible person. And we should use a dose of statin to start with that people are more likely to tolerate, rather than using the highest available dose of statin right out of the gate. If we do that, I think we create opportunities for people to be more successful. There are also other issues. If you have a very low vitamin D, if you have hypothyroidism, an underactive thyroid, these are medical conditions that set you up to ache and pain on a statin. So depending on what else is going on with the patient, we can find ways to help. Some of it may be a different strategy, using a non-statin medicine right off the bat. So there are medicines that lower LDL that are not a statin. And you can put the things backwards. If a statin is a problem, start with the non-statin, like ezetimibe or Zetia. Decreases cholesterol absorption in the gut, decreases heart attacks, doesn't have the same adverse effects as a statin, gives people confidence if they need a medicine, they can take a medicine, and if necessary, we can add a lower dose of statin to finish off where they need to go to. So these are just a couple of strategies that could be helpful for people to try on for size if they're getting the feedback from their provider. I think you need to be on a statin for all the right reasons. In most cases, I have found that there are ways that we can help people get on some dose of statin. There are some people who can't take anything, I get that, but that's not the norm.
Well, folks, thanks for joining us again. I'm here with Dr. William Cromwell. He's a lipid specialist in Raleigh, North Carolina, and we've known each other for a number of different years. We worked as colleagues on different kinds of cases. And Dr. Cromwell's exploring some interesting new avenues. As you know, as you've heard earlier in our discussion this evening, there are multiple factors that come into play in terms of creating this plaque, this buildup in our arteries, and it could be in different places. It manifests itself in different ways. We've talked about stroke, we've talked about heart attacks. So I want to kind of pick his brain a little bit about, here's a scenario, Dr. Cromwell, I'll give you. And, I'm a patient, and I've just found out that on a fasting blood analysis, my blood sugar is just a little bit off. I was told it was 105, and I was fasting. I hadn't eaten anything. I behaved. But I really don't know, where do I go with that? How do I, is this something I really need to be worried about? How does it dovetail with other things that I might need to know, or that my doctor might need to know in helping me through this? Because I think one of the things I heard you say was that this can be a risk factor. And the last thing I want to do is become a diabetic. And when I hear the word pre, that means, well, I could go one way or I could go the other way. And I'd like to go the good way, but can you put this in more practical terms and in the areas that you've been investigating of late?
Right. Well, it's a great question, because the way diabetes is basically categorized now is all based on blood sugar. If you're over 125 fasting glucose on multiple occasions and you're not sick, you've crossed the line from pre-diabetes into diabetes. And if we back up a little bit, if you're over 100 and up to 125, you're a pre-diabetic. So that's a pretty broad range. And what the American Diabetes Association would say is that pre-diabetics as a group have a higher risk of developing diabetes over time than people who don't have pre-diabetes. Well, that's a pretty general statement. It's true, but there's more to the story. So let's say you have 105 glucose for your patient, and I have a patient who has 105 glucose. So they both have the same glucose. Do they have the same likelihood of developing diabetes in, say, the next 8 years? And the answer is no. There's a tremendous difference. And this is where research over the past 10 plus years that we've been involved with has been very interesting. And that is that there is a wide range of individual risk of diabetes at any given glucose value. So what's the rest of the story? Well, we go back to this insulin resistance conversation we had before. Insulin resistance is what sets you up for prediabetes. Insulin resistance is the driver under the hood that's making this engine run. And so there is a way that you can actually look at your insulin resistance score. We call that an LPIR score. It's done by nuclear magnetic resonance. And it's a very interesting marker in that it is highly significant for who develops diabetes in the future independent of many things that people normally think about, independent of your blood sugar level, independent of how big your belly is when you put a tape measure on it, independent of your body mass index, and many other things. And so it's highly predictive. And what's interesting is you can take the LPIR score, combine it with your fasting glucose, and come up with an estimate of 8-year risk for an individual. So in our example, 105 glucose for patient 1 and patient 2, if you have a high insulin resistance score, at the same glucose, you will have a much greater risk of diabetes in 8 years. If you have a low insulin resistance score, at the same 105 glucose, you will have a markedly less risk of diabetes in 8 years. And so in order to give an individual better information about themselves, we have to combine the two. And this is what we do with Precision Health Reports. It's an opportunity, as you know, for us to bring precision to individual reporting using the patient's individual information so that they have a better idea what is my risk for diabetes if you just had 2 pieces of information instead of 1. My LPIR score and my glucose instead of just my glucose. And so your listeners who are interested in this can contact you because you've got a lot of information that you can share with them about this. But this is an example of where we don't have to guess. I hate guessing as far as patients are concerned. And medicine to some degree is taking the best data you have and trying to do what you can with it. But we're at an age now where you don't have to just look at glucose and say, if I had 1,000 people like you, X% going to get diabetes. I can say, in your case, given your insulin resistance and your glucose, your risk is 50% in the next 8 years. Well, that's sobering. And what do I do about that? We're back to our previous conversation. Diet, exercise, significantly improve insulin resistance. And as insulin resistance improves, risk of diabetes goes way down. So these are ways that people can be empowered. People who are getting the right information from you and from others, who are making the lifestyle changes that are appropriate, can track their LPIR score. They can track their glucose. They can track their 8-year risk of diabetes and say, it's working. And that's motivating to continue the hard work of making a sustainable change. Or in some cases, maybe it's not working. And that's a chance for a different conversation to say, well, I know what we said, but tell me what you're doing. and then there may be a rest of the story, right? And say, right. I guess some of that didn't actually stick, and we need to drop back and come up with a new plan and do something a little different. It's all about giving people options that work. But if you don't know where you are and you can't follow your response to therapy, you really are kind of groping in the dark. You have no idea whether these concepts of diet and exercise are actually working in your case. And so why would you stick with that? Why would you do something hard for the next 5 years, 8 years, if there's no evidence that it's improving? So I think this gets back to the idea of actionable information. Giving people stuff that makes a difference, that they can understand, that they can make the changes and see if it works. And if it is, it motivates the continued change. And if it doesn't, we can do something different. And this is something I would encourage your listeners to reach out to you to discuss because, locally you're one of the resources I think that could be very helpful to them in this.
Well, thank you. Thank you so much. Dr. Cromwell, it's been fascinating spending the past hour with you. I know our listeners are probably just as engaged. And folks, you've learned from an expert this evening. And I certainly appreciate that. And I think there was a thread through a lot of what was said. And I heard more than once, personalized, more time to work with the patient. When you're talking about lifestyle intervention, this is not an easy thing. It's far easier to actually write a prescription, tell you the side effects, and say, go take this at a certain rate, a certain time, a certain interval,
right,
and just see you back in 3 months and we'll monitor the efficacy of that intervention. But it is a lot harder. And folks, when you're thrown, take this diet, do this, and see you back, it's an empty feeling, I think, for the patient, and honestly for the provider. We know we're not probably doing the job we need to, and having that time to sit down and really ponder and think through case by case on an individual personalized basis, that adds volumes to patient care. And quite honestly, that's what I'm enjoying so much about my current practice. And it's being able to bring in resources to our community like Dr. Cromwell that just gets my boat floating, and it really generates a lot of satisfaction. So again, folks, we're going to have other talks in the coming months. There'll be a listing that you'll see of the next shows. We will open the lines at some point, but I wanted to get as much information out to you for life-changing information. This has been valuable, I hope. Let the station know that you appreciate them having us on, and give us a call. You can see the number at the bottom of the screen. It will flash it up. We are always welcoming new patients in our MDVIP practice. It's a chance to deliver that personalized health care, kind of going back to many, many years ago when it was really the patient and the doctor were close. They had that relationship, but now we have new technologies, new interventions, as Dr. Cromwell mentioned, bringing new technologies to bear to understand how to better treat you as a whole patient. So that's what we do at MDVIP. We'll have more about that in the coming months. Thanks so much, and we wish you the very best of health. Thank you.